Hello everyone. In this session, we are going to discuss about basic life support and advanced cardiac life support based on the 2020 AHA or American Heart Association guidelines. Let's begin. Now, cardiac arrest according to AHA is broadly classified into out-of-hospital cardiac arrest as well as in-hospital cardiac arrest. Why this classification is because the challenges that we face to improve the outcome in out-of-hospital cardiac arrest is different from in-hospital cardiac arrest. The prognosis is entirely different. In out-of-hospital cardiac arrest, according to US registry, only 10.4% people survive and only 8.2% will have good functional outcome. Now, the key problem here or the key limiting factor here is the lay rescuer CPR. The layman is not able to identify cardiac arrest and they do not know how to start or how to give CPR. So it's seen that in US population itself, only about 39.2% of out-of-hospital cardiac arrest patients receive CPR. And AED, which is automated external defibrillator, it's a device which we use to defibrillate or deliver shock outside the hospital. It can be used by laymen whenever they witness a cardiac arrest. And in the developed population itself in US, the use of AED is only 11.9%. Now, when it comes to our country, some studies have shown that the lay rescue CPR or bystander CPR that our population receives is only less than 2%, which is way less compared to the US population. Now, compared to out-of-hospital cardiac arrest, where only 1 out of 10 patients survives, in-hospital cardiac arrest has a much better prognosis, in that about 25.8%, roughly 25% of in-hospital cardiac arrest patients will survive, and most of them, up to 82%, will have good functional outcome. So 1 out of every 4 in-hospital cardiac arrest patient will survive with good neurological outcome. Alright. Now, in order to improve the outcome for both out-of-hospital as well as in-hospital cardiac arrest patients, we need a system. Alright. A system with a lot of elements, and all these elements have to work together seamlessly in the form of a chain, and each of these elements form the link of that chain. This is something called as the chain of survival. Now, you can see that it has 6 components. What you need to know is that a lot of new updates have come in the 2020 guidelines. And in the chain of survival, one of the latest update is the adding of the recovery link here. Okay, in both out-of-hospital cardiac arrest and in-hospital cardiac arrest. Why this link has been added is that because we have realized the fact that the rehabilitation or recovery from cardiac arrest takes a long time. It's almost like stroke. Alright, the patient can take a variable period of time from days or weeks or months to maybe even years for complete neurological recovery after a life-threatening event of cardiac arrest. So we have to rehabilitate these patients for a long period of time, and it's very important for the functional outcome. That's why the link recovery has been added. This is the sixth link in the chain of survival. Now let's look at all the other links. The first one, we will go through the out-of-hospital cardiac arrest scenario first. First thing here, the most important thing is activation of the emergency response system. Alright, and for that you need to recognize that the patient has gone into cardiac arrest. Okay, so a layperson or a healthcare provider outside the hospital has to recognize that the patient has gone into cardiac arrest and he has to activate the emergency response system. In US and all, the emergency response system may be 911. Alright, here we can either call 108 or 112. It varies here in our country. Okay, so activation of the emergency response system, and you can see that this link, there is a new change in the 2020 update. They have put the picture of a mobile phone because now they have recognized, AHA has recognized that almost everyone has a mobile phone, and if you are alone and you are witnessing a cardiac arrest, you can use the mobile phone to call the emergency response system number. All right. Okay, when it comes to in-hospital cardiac arrest, the first link is always early recognition of a sick patient and prevention of cardiac arrest. Here, there is an opportunity for us to prevent cardiac arrest. So, this link is somewhat different from the out-of-hospital cardiac arrest link. Because prevention of cardiac arrest is very important. Even though CPR and all may be exciting for us, it's not at all good for the patient. All right. The outcome is very bad. Only 1 out of 4 patients in hospital cardiac arrest will be surviving. All right. So prevention of cardiac arrest is a vital part of our practice. Okay. Now, after if you are not able to prevent cardiac arrest inside the hospital, if the patient goes into cardiac arrest, then you need to activate the emergency response system. So the second link here is actually the first one in out-of-hospital cardiac arrest. All right. And once you recognize cardiac arrest, now the question comes, how do you diagnose cardiac arrest or how do you recognize cardiac arrest? All right. Now, after recognizing cardiac arrest, then the most important step here is to start high-quality CPR. All right. High-quality CPR, what are the components of that? We will discuss soon. And it has to be associated or it has to be supported along with defibrillation. Early defibrillation is also an important link here. Okay. High-quality CPR, early defibrillation in both the chains. And after that, in out-of-hospital cardiac arrest, you move on to something called as advanced resuscitation. So whatever we did till now can be divided into basic life support, or that's the fundamental thing or the basic thing which we need to start whenever we identify a patient to be in cardiac arrest or a victim to be in cardiac arrest. And after that, we move on to advanced cardiac life support. But this link is not mentioned in the in-hospital cardiac arrest chain because it's expected that we quickly move on to ACLS inside the hospital. Okay, so you can see that it's actually a continuation from BLS to ACLS. We always start with basic life support, which mainly includes high quality CPR, defibrillation and basic airway management, and we proceed to advanced cardiac life support as soon as we have the adequate supportive elements there. Okay, or the equipment as well as the people there. And you can see that once we have achieved or we have brought back the patient to having signs of life, or what we call as a return of spontaneous circulation, or simply the patient has a pulse back, we move on to something called as a post-cardiac arrest care. All right. And finally, after initial stabilization and all those things, we move on to the phase of recovery. All right. So recovery part, maybe the emergency department as well as the ICU department may not have a huge role because the rehabilitation is a long-term process. But till then, the BLS as well as ACLS and the post-cardiac arrest care has to be done from the emergency department as well as the ICUs. All right. So it's a spectrum, or you can call it as a continuation. All right. Now let's go through each of these things. First of all, basic life support, or BLS as we commonly call it. The important steps here is recognition of cardiac arrest, activation of the emergency response system, high quality CPR, basic airway management, and early defibrillation. These are the components of the basic life support. All right. Whenever we use any drugs or whenever we go for advanced airway management, we are actually moving on to advanced cardiac life support. Okay. Now the first and most important step, which is sort of the rate limiting step in the out of hospital cardiac arrest scenarios, is the recognition of cardiac arrest. All right. we always get patients brought into the emergency department in cardiac arrest without the bystanders giving CPR. Okay, the reason for this is because laymen are not able to recognize cardiac arrest and they may not be knowing how to do CPR actually. So recognition of cardiac arrest, we mainly use a triad of 3 findings. First of all, the patient has no response. He is completely unresponsive. And then the patient has no pulse and he is not breathing, or he may have only something called as agonal breathing. Alright, agonal breathing is not normal breathing. Okay, the patient could be in cardiac arrest. He may not have any pulse at all, but the patient can have a reflex sort of agonal breathing. Even in such patients, we have to start CPR. Okay. Now, this is an algorithm provided by American Heart Association for basic life support. I will just magnify that. Okay. The first and foremost thing is to make sure that the scene is safe. Alright, this is mainly for out of hospital cardiac arrest scenarios. Maybe the patient could have went into cardiac arrest following electrocution, alright, or maybe he may have undergone drowning, alright. We have to make sure that the scene is safe, that the electrical line has been, the power line has been cut, as well as the patient has been pulled off the whatever place where he drowned, and all kind of things. All right, maybe there might be a fire there, the patient went into cardiac arrest because of smoke inhalation. We have to make sure that our own safety is given the first priority, followed by the patient safety. Okay, if somebody collapses in the middle of the road, we are not going to start CPR there, right? We will move the victim to the side of the road and we'll start CPR or further assessment from there. Okay, that's about scene safety. And after that, we need to make sure that the patient has gone into cardiac arrest, because anyone can collapse because of a lot of other conditions, like maybe a syncope, maybe seizure, or maybe hypoglycemia. All right. So first of all, we need to diagnose cardiac arrest here. So we will check for responsiveness. And if the patient is not responsive or the victim is not responsive, we will call for nearby help, because a cardiac arrest victim management requires a lot of additional personnel. All right, you cannot do much all by yourself. Okay, so shout for nearby help, and after that, activate the emergency response system via a mobile device. All right, then get AED and emergency equipment, or if there is someone else there, you can ask them to bring them. Okay, so this should be the ideal scenario. All right, but unfortunately in our country we don't have AEDs that freely available. Okay, and after that, if the patient is not responsive and you have activated the emergency response, you check for pulse as well as breathing simultaneously. All right, simultaneously. Is pulse definitely felt? And you should check for pulse in the carotid area. You are checking mainly for the carotid pulse only, not the radial pulse or any other pulse. The main central carotid pulse. Okay, and you should check for at least 5 seconds so that you might not miss a bradycardia. Okay, if the patient is bradycardic but has a pulse, you don't have to start CPR. That's why we check for at least 5 seconds, but you shouldn't wait or waste time for more than 10 seconds. All right. If you are in doubt whether there is pulse or not, assume that the patient doesn't have a pulse and you start CPR. Okay. Now, let's consider the different scenarios to the left here. Okay, here the patient has normal breathing and pulse is felt, but the patient is unresponsive. In such cases, monitor until emergency responders arrive. After that, you can shift the patient to the hospital. But to the right, you can see that no normal breathing, but pulse is present. That is, the patient has gone into a respiratory arrest scenario, but the pulse is present. Any moment, the patient can go into cardiac arrest as well. So if respiratory arrest alone is there, you provide rescue breathing. How do you do that? By mouth to mouth in out of hospital setting. You give one breath every 6 seconds or at the rate of 10 breaths per minute. And you need to make sure that the pulse is present every 2 minutes. If there is no pulse, you need to start CPR. No pulse, always start CPR. And if possible, opioid overdose. This is not that rampantly common in our setting, but it's becoming more common. But in US setting and all, opioid poisoning, opioid overdose is a common thing, and there has been a lot of mortality due to that. So you always need to consider opioid overdose as well whenever the patient has gone into respiratory arrest. And if you're suspecting that, you can administer naloxone if available, of course. Now, the scenario that we are worrying about, no breathing or only gasping, and there is no pulse. That means the patient has gone into cardiac arrest. Immediately start CPR. All right. And in CPR, we know the sequence is going to be CAB. Now, before 2010, all right, before 2010, it was ABC. That is airway, breathing and circulation. People were asked to open the airway first, give 2 breaths, followed by starting chest compression. But after 2010, the sequence has been changed to chest compression first, then airway, and then breathing. All right. So you start with chest compression at a ratio of 30 compressions and 2 breaths. And of course, before giving breath, you need to open the airway. All right. And you use AED as soon as it is available. All right. Now, if the AED arrives, you need to connect the AED. And after you attach the AED is automated external defibrillator, as I already said. It has usually 2 pads which you can attach to the infraclavicular area on the right side as well as to the apex on the left side. Okay. And you just have to turn on the machine and it will start analyzing whether the patient has something called as a shockable rhythm or a non-shockable rhythm. This is because cardiac arrest patients can have either a shockable rhythm which can respond to your defibrillation or a non-shockable rhythm which doesn't respond to any shock that you give or to your defibrillation. Okay. So assessing this is very important because early defibrillation is very important in cardiac arrest scenarios, because we will see that later that the earlier you defibrillate the patient, the better the survival outcome is for the patient. Okay. So if the patient is having a shockable rhythm, then give 1 shock here. A shockable rhythm, give 1 shock, and after that resume CPR immediately for 2 minutes. Okay. The 2-minute count will be done by the AED itself. You can actually hear that. Okay. Then after 2 minutes, you again see if there are any signs of life, like the patient is having any spontaneous breathing, not agonal breathing, but spontaneous breathing, whether the patient is having any responsiveness, he has become conscious, or if the patient is having any pulse. Okay. If it is not present, you check again the rhythm. Okay. If it's still a shockable rhythm, you continue. You deliver another shock, the machine will deliver another shock, and you continue your CPR. All right. Now, after attaching the AED, if the AED diagnoses it, analyzes the cardiac arrest rhythm to be non-shockable rhythm, then there is no point of giving a shock here. Okay, you continue CPR for next 2 minutes. And after that 2 minutes, the AED will prompt you to stop CPR and it will analyze the rhythm again and tell you whether it's shockable or non-shockable. If it's shockable, you deliver a shock here. All right. If it's non-shockable, you immediately continue CPR. Okay. So that's the algorithm for BLS provided by American Heart Association. Okay. Now, in that, we are going to discuss about high quality CPR here. Okay. High quality CPR. What do you mean by high quality CPR? What's the immediate goal of high quality CPR is to provide something called as ROSC. Okay. To get back ROSC, as we commonly say it. ROSC is return of spontaneous circulation. All right. Why we are giving chest compression is we are sort of providing artificially pumping of the heart, right? We are artificially trying to externally pump the heart so that the circulation can be maintained at least to the vital organs, which are the heart as well as the brain. Okay. So the immediate goal of giving high quality CPR is to get ROSC, or return of spontaneous circulation, which we identify by looking at the pulse. But the ultimate goal is to always give back to the society a functionally as well as neurologically independent or intact individual. Okay. So basically how the patient or how the victim was before the event, we need to try to give that kind of person back to the society. Now, the high quality CPR has 5 main components in it. The first one is the most important one, is to push hard and push fast. All right. Push hard with at least a depth of 5 centimeter or 1/3 of the anterior posterior diameter of the chest. All right. At least 5 centimeter, you need to press the sternum down. All right. We are keeping the hand for CPR like this over the sternum, over the lower half of the sternum, and we need to apply enough force so as to depress the chest or the sternum up to around 5 centimeter. All right. The book also says that we shouldn't go beyond 6 centimeter, but it's very hard to measure, right? Okay, so at least 5 centimeter is the most important point here, and you need to provide chest compression at a rate of 100 to 120 per minute. Okay, so we usually take a mid-range of 110 per minute and we usually target that. Now, as we have already seen, the ratio of compression to ventilation or artificial breaths is 30:2. We provide 30 compressions at the rate of 100 to 120 per minute. So usually we will give 30 compressions in about 18 seconds, and this is followed by 2 artificial breaths or 2 ventilations. Okay, so this is something called as a universal compression ventilation ratio. So in all adults and all pediatric patients or even infants, whenever there is only a single rescuer, whenever you are alone there, you will go for a 30:2 ratio. That is called as universal compression ventilation ratio. But in children, whenever you have 2 rescuers, this ratio kind of changes to 15:2. All right. We will learn about adults only in this session. All right. Next important step or the component of high quality CPR is allow complete chest recoil. Okay, this is very important because after you squeeze the sternum or squeeze the chest up to 5 centimeter, you need to completely allow the chest to recoil back. Okay, this phase is important because it is during this phase the venous return into the heart happens. Alright, just like the diastolic phase of cardiac cycle, this is the phase where venous filling or the venous return into the heart happens, so that in the next compression you can squeeze out this blood and provide the supply to the brain, provide perfusion to the brain as well as the heart. Okay, that's why we are limiting the rate to 120 per minute. See, whenever you go beyond 120 per minute, there is always this chance that you will compromise the chest recoil component. So you won't be providing adequate chest recoil. So we will limit the rate to 120 per minute. The next important component is to switch compressors. Okay, switch compressors about every 2 minutes or earlier if fatigued. Why AHA recommends to switch compressors at least every 2 minutes is that pushing at least 5 centimeter at a rate of 100 to 120 per minute, it's not very easy. Okay, even healthy people can push for a maximum of at least 2 minutes, and after that they will somewhat start to compromise the quality of CPR. So after 2 minutes you switch and someone else will take over the compression. Okay, and the switching has to be done in a rapid way that it takes only about 5 seconds. So the next person or the next compressor has to be ready right behind the initial compressor to take over chest compressions as soon as 2 minutes is hit. The next and most crucial step is to minimize interruptions in compression. to 10 seconds or less. Okay, minimizing interruptions in compressions is very important because of something called as coronary perfusion pressure. Okay, now the coronary perfusion pressure is the difference between the aortic diastolic pressure or the aortic relaxation pressure and the right atrial pressure. So this is the pressure which actually perfuses the coronaries, okay, the coronary arteries. Now during CPR, what we have seen is that, what studies have shown is that as soon as you start the chest compressions, the coronary perfusion pressure will start to increase from 0. Okay, so here it's 0 and it's slowly increasing here. Okay, you can see it increasing here. And in about 10 compressions, after about 10 compressions, it will go beyond a value of 15 millimeter of mercury. Okay, now studies have shown that ROSC is more likely when the coronary perfusion pressure is kept above 15 millimeters of mercury. Okay, so you can see it takes a few compressions for this pressure to reach above 15 millimeter of mercury, and once you reach 30 compressions and you interrupt it for ventilation, you can see the coronary pressure perfusion CPP rapidly falls down to 0. Okay, so there is a period of no perfusion here, and then again it has to rise slowly up till it reaches up to 15 millimeter of mercury. So every interruption is going to affect the outcome or the survival of the cardiac arrest victim. Alright, so it's very important that we minimize interruptions in compression. What all situations can there be interruptions? The interruptions that we allow is whenever we are giving artificial breaths or ventilation. So for each breath, we are allowing 1 second. So both breaths, we are giving 2 breaths, right? 30:2 ratio, 2 breaths. So 2 breaths should take at only about 2 seconds. Okay. And then we are allowing this time period for analyzing the heart rhythm, right? But even analysis of the heart rhythm should be restricted to less than 10 seconds. Okay. Then other places where the interruption can occur is when after 2 minutes you are switching the role, but we usually combine that with the analyzing part. Okay, analysis part. Okay, we will come to that. Then you can have interruption if when you are trying to intubate the patient, right? So we have to somehow try to reduce all these interruptions to minimum, less than 10 seconds. Okay. Now, all these components of high quality CPR are very important that the AHA now recommends the routine use of CPR feedback devices. Now, this is a 2020 update. Okay, to routinely use CPR feedback devices that can actually assess the depth of compression as well as the recoil that we are providing, and along with that, the rate of the compression is also measured. And you can see those things real time while giving chest compressions. Now, if available, AHA recommends that we can use even automated CPR devices. Now, Lucas device is one such automated device, okay, for providing CPR. Its expansion is Lund University Cardiopulmonary Assist System. Now, you can see that it can be used in pre-hospital settings when you are transporting patients, out of hospital cardiac arrest patients inside to the hospital. You can even use it inside the hospital. All right. Okay. So what studies have shown that it has increased the ROSC rates in the emergency departments. Higher rates of ROSC has been achieved, and you can see that it can be used to deliver CPR while even performing angioplasty. Okay, percutaneous coronary interventions. Now, the last component of high quality CPR is to avoid hyperventilation, because hyperventilation, whenever what we are giving by using mouth to mouth or even back mask ventilation is something called as positive pressure ventilation, right? We are pushing air inside. Whenever we push in air, positive pressure ventilation results in positive intrathoracic pressure. This will impede your venous return. Okay, so the cardiac output will ultimately be on the lower side whenever if you are hyperventilating these patients. So how to ventilate these patients properly? So if you are giving mouth to mouth, then compression ventilation ratio will be 30:2. Okay, only 2 breaths are given after every 30 compressions. If you are using back mask ventilation also, the same ratio is used, 30:2 ratio. But if you are having an advanced airway, alright, advanced airway in the form of intubation, or you are using a supraglottic airway like King's laryngeal tube or a laryngeal mask airway, then the compression ventilation ratio actually changes. Then we do something called as asynchronous compression and ventilation. Okay, the advantage here is that you don't have to interrupt the compressions. So the 30:2 ratio will not exist. You can provide continuous compression for 2 minutes. And in between that, you can provide 1 breath every 6 seconds. Okay, so continuous compression and 1 breath every 6 seconds. Alright. So this is back mask ventilation using an ambu bag. Now these are the examples of advanced airway, the endotracheal tube intubation, or this is something called as King's supraglottic airway device or laryngeal tube supraglottic device. Then this is laryngeal mask airway. Okay, if you are using any of these devices, it becomes an advanced airway and you have in fact actually moved on to advanced cardiac life support. Okay. Now, I have already mentioned that the CAB sequence, of course, before providing these breaths, artificial breaths, you need to open the airway. You can use either a head tilt chin lift maneuver if you are going for mouth to mouth breaths. Alright. Okay, what it does is it brings the tongue backwards because the tongue is the organ which causes upper airway obstruction. Or you can use a maneuver, something called as a jaw thrust maneuver. Okay, this is what we use along with a back mask ventilation. Now, how to hold the ambu bag or provide back mask ventilation? We use something called as a EC or CE clamp technique. Alright, you can see that this part here is in the shape of a C to fix the mask onto the face, and we are providing jaw thrust with our fingers here which forms an E. Okay, this is the CE or EC clamp technique. So those are the components of high quality CPR which we have discussed. Just to recall it, the first one is to push hard and push fast. Push hard at a rate of at least push hard at a depth of at least 5 cm and push fast at a rate of 100 to 120 per minute. You target a mid-range of 110 per minute. Then allow complete chest recoil in between compressions. Then switch compressors every 2 minutes or whenever someone gets fatigued. Alright. Then the fourth one is to minimize interruptions in compressions. Remember the coronary perfusion pressure target of more than 15 mm mercury. And finally, avoiding hyperventilation. The 5 components of high quality CPR. Alright. Now, the next crucial step is defibrillation. Okay. Early defibrillation is one of the key things to increase the survival. Alright. What is the purpose of defibrillation? The use of AEDs or manual defibrillators. This is because whenever a person or a victim goes into cardiac arrest, he can have 4 rhythms only, 4 ECG rhythms only. Alright? We can basically classify them into shockable rhythms or non-shockable rhythms. Shockable rhythms, we have an opportunity to shock and there is higher chance of ROSC happening. In non-shockable rhythms, there is no point in giving shock here. Okay, so the shockable rhythms are again 2, which is ventricular fibrillation or VF as we commonly call it, and pulseless VT or pulseless ventricular tachycardia. Alright, we can mark it as PVT. Okay. Then the non-shockable rhythms are, of course, asystole, which we commonly see as a flat line on the monitor, or pulseless electrical activity, which means there is an organized rhythm. It can be anything. It can be a sinus rhythm, it can be sinus tachycardia, it can be an atrial fibrillation, any rhythm. It can be ventricular activity only, like an agonal rhythm. But there is an organized rhythm then. There is a QRS complex you are able to identify without the patient having a pulse. This is called PEA, or pulseless electrical activity. Alright. Now, defibrillation is the treatment which we give in a shockable rhythm. That is, the patient is having, we have identified the patient to be having either ventricular fibrillation or the patient is in pulseless ventricular tachycardia. Okay. Now, what we do in defibrillation is that we actually pass current. We actually sandwich the heart between two pads or paddles, and we are passing current in both directions. Okay. We are trying to depolarize the entire heart in one go. We are providing a shock so that all the electrical activity inside the heart will come to a standstill. Okay. Now, when all the electrical activity comes to a stop there is a chance that if viable, the pacemaker, the normal pacemaker or the sinus node of the heart will be able to restart and produce an electrical activity as well as pulse there. Okay. So that's the purpose of providing defibrillation, or some people call it as a DC shock. We are using DC current here. Alright. Now, early defibrillation is very important, as you can see in this chart. As the time to defibrillation, so this was a study in ventricular fibrillation sudden cardiac arrest patients, and the time from collapse to defibrillation you can see here on the x-axis. As the time increases, you can see that the survival comes down. Okay, the survival drastically decreases. For every minute delay in defibrillation, you can see about 10% decrease in the fall in the survival rate here. Alright, but whenever you give CPR, this fall in the rate of survival will be reduced. Okay, if every minute there is a fall in 10%, when you give CPR, this will count down to around 3 to 4%. Okay, that's why the importance of starting CPR even when there is a shockable rhythm. So early compression is very important here, as well as early defibrillation is very important here. Now, defibrillation, just for completion's sake, of course, AHA recommends external defibrillators, but we should know that there is something called as internal defibrillation as well. So, external defibrillation is provided either using AED, automated external defibrillators, in out-of-hospital settings, but in hospital cardiac arrest settings, we are using mainly a manual defibrillator. This is a manual defibrillator. Okay. Now, suppose the patient is undergoing a cardiac thoracic surgery and the chest is open, the heart can be visualized. We can use internal defibrillation paddles, any use in ED or in the ICU settings. Okay. Then the another kind of defibrillator that you should at least know is that there are implantable cardioverter defibrillators, ICDs. Patients who are at risk of these ventricular or life-threatening arrhythmias, before going to cardiac arrest, they will get a shock there. Okay, we are implanting such defibrillators inside. Alright, it's just for completion's sake I am saying those things. Okay, now let's move on to ACLS. Okay, so all these parts, high quality CPR, defibrillation, it comes from under BLS actually, and it's a continuation into the ACLS part. Now, when we talk about advanced cardiac life support or ACLS, this means that you have activated the emergency response system and the code blue team or your cardiac arrest team or your resuscitation team has arrived there. Alright. Now, these are called as high performance teams. Okay. AHA calls them as high performance team in the 2020 update. Okay. Then how ACLS is different is that from BLS, we are actually monitoring the rhythm, okay, using a manual defibrillator. We are making the diagnosis of whether it's a shockable rhythm or a non-shockable rhythm rather than using an AED. Okay. Then we are monitoring the quality of CPR. We are using various drugs. We may go for an advanced airway, and we will be thinking about the underlying cause of cardiac arrest, and we will try to treat them. These are called treating the reversible causes of cardiac arrest. So all these steps come under the ACLS part. Okay. Now, the high performance team, what makes this team high performance is that why we are calling them as high performance team is that they always ensure that we are providing high quality CPR in a timely manner. So the first compression will be started very early. They will aim for early defibrillation. They will aim for compressions without any interruptions. They usually target a chest compression fraction of more than 80%. Okay, and at the same time, they will be monitoring all the things, the quality of the CPR, and after that, they will undergo a feedback session or a debriefing session where they will discuss how they can improve further. All right. So continuous quality improvement is what makes these resuscitation teams into high performance teams. Okay. Now, chest compression fraction is something very important that could be a question in your exams. So chest compression fraction means it is the proportion of time. Okay. It's a proportion of time during cardiac arrest resuscitation that the rescuer is performing chest compressions. Okay. So CCF is time of chest compressions. How long or what is the time we are actually compressing the patient by the total time, that is from recognition of cardiac arrest till we get ROSC. Okay. In that total time, how much time we are spending for chest compression. Ideally, AHA recommends that we should target more than 80%. But for good outcome, at least we should target more than 60%. Okay, otherwise we are not called as a high performance team. Now, there are different ways which AHA recommends to increase the chest compression fraction. This is also a 2020 update. Okay. One thing we can do is something called as pre-charging the defibrillator. So, we have already mentioned that every 2 minutes we switch the compressors, right? And during that period, we are actually analyzing the heart rhythm as well. Okay, that's the basic thing that which we do in BLS, right? And before reaching that 2-minute mark, what we can do in ACLS is that we can actually pre-charge the defibrillator, assuming that if the next rhythm on analysis, if it's a shockable rhythm, we are going to defibrillate immediately. Okay, so when we reach at a time of about 1 minute 45 seconds into chest compression, we will start pre-charging the defibrillator. It takes about 5 to 10 seconds for the defibrillator to get charged up to the energy we desire. Okay, so usually we use an energy of 360 joules in a monophasic defibrillator, or between 120 to 200 joules if it's a biphasic defibrillator. Most of the modern defibrillators are biphasic defibrillators. So we will select the energy and we will charge it till before it's 2 minutes. Okay, and another thing that we can do is that during the pre-charge phase, or just before 2 minutes, we can ask someone to keep a hand over the femoral artery. Okay, so we can feel a pulse during chest compressions. All right. Now, if the patient after 2 minutes on rhythm analysis has a non-shockable rhythm or an organized rhythm, to be more specific, right? Asystole, we are not going to check for pulse. Or if it's a shockable rhythm, we are not going to check for pulse. But if we are having an organized rhythm, we need to differentiate whether the patient has achieved ROSC, that is a spontaneous pulse has come, or whether the patient is in PEA. So this again, the pulse check again takes 5 to 10 seconds time, right? So what we can do is that we can ask someone to be ready there. They can palpate the femoral artery and be ready there. And if it's an organized rhythm, they should know whether they should tell the team whether there is pulse or not. If the pulse is present, ROSC has been attained. If it's not present, it's PEA, right? Okay, so these things can be done early itself. Okay, the next most important step is for the compressor to hover over the patient's chest. Hovering over is just keeping the hands over the patient's chest without touching it, but being there ready to deliver the next compression. So after 30 compression, the compressor will hover over the patient's chest. Okay. Now have the next compressor ready to take over before the 2 minutes it's up. Then intubate without pausing compressions. Okay. This is a challenging thing, but if it's possible, the experienced provider may intubate even while chest compressions is going on. But if it's kind of difficult, you can actually, AHA allows you to pause compressions, but not more than 10 seconds. So you get the laryngoscope in, you visualize the vocal cords, and you ask them to start compression just for the time taken by you to pass the ET tube inside. Then deliver medications also during compression. Okay, no need to stop compressions during that. So these are the main team members of a high performance team. AHA recommends at least 6 members there. The first and most important person is going to be the team leader here. Okay, the team leader. The team leader usually stands at the foot end and he monitors every other, and he actually thinks about the underlying causes of cardiac arrest, and he's like a master of an orchestra, okay, bringing everything together. All right. Then the most important person is going to be the compressor here. The compressor here. Then there will be an airway person and one person to handle the defibrillator, and this person has been given an additional role in the 2020 guidelines as the CPR coach as well. Okay. Now the CPR coach, it's the role, ensuring high quality CPR. That responsibility has been taken over by the CPR coach from the team leader. Earlier, before 2020, the team leader used to monitor how the CPR quality was, how the chest compressions were being delivered, whether the ventilation were being given adequately, everything was being done in a timely manner. But now that responsibility has been handed over to the CPR coach, okay, to ensure high quality CPR. So after delivering a shock, the defibrillator person is usually free, and his responsibility is to make sure that they all work together in a form of triangle to provide high quality CPR. Okay, then we need to have one person to get the IV line or IO access, as well as to give medications and to draw samples for lab investigations. Okay, and then we have something called as a scribe or a recorder who records all the events, all the medications that we are giving, and he is the person, or he or she is the person who keeps track of the time. Every 2 minutes, he will inform the team leader. The next most important thing that we do in ACLS is that we monitor the rhythm. And the ACLS adult cardiac arrest algorithm, it actually is built around this rhythm analysis. All right. Now we need to go a little bit deep into this algorithm. A lot of questions can come from this part. So of course, we start with BLS, and you can see that here we have started the CPR. We will start the patient on oxygen, and we will be supplementing 100% oxygen here. In cardiac arrest, respiratory arrest patients, we will always give 100% oxygen. Okay. And the next most important step is to attach the monitor or defibrillator. So till then we are giving CPR. As soon as the defibrillator is attached, we'll stop CPR, we'll stop the chest compression to do a rhythm analysis. Alright? And this part should be done within 10 seconds. And we are going to divide the algorithm into 2 parts here, based on whether it's a shockable rhythm, ventricular fibrillation or pulseless VT, and a non-shockable rhythm, whether it's asystole or PEA. Alright? Now let's go through the arm which discusses the shockable rhythm. Now when you identify a VF or a pulseless VT, you need to immediately deliver a shock. So I have already mentioned that we will pre-start the defibrillator before rhythm analysis, before that 2-minute mark. And when we identify it's a shockable rhythm, we will deliver shock immediately. Alright, so this is the first shock here. Okay, and we are going to continue CPR for next 2 minutes. Okay, immediately after delivering shock, we are not going to look whether the rhythm has been corrected, whether the patient has got sinus rhythm. Why we do that is that even after complete depolarization, it takes some time for the sinus node to start its normal pacemaker function. And it takes some time for the heart to start its contractility action. So the cardiac output, meaningful cardiac output will come only after a few minutes, even if you are able to completely stop the arrhythmia here. Okay, till that time we have to support the patient by external chest compression. Okay, so in that 2 minutes time, we are going to get the IV IO access, and we will debrief the team what happened to the patient and all kind of things like that. Okay. And after 2 minutes, we will do a rhythm analysis again. Alright. So this is the second time we are analyzing the rhythm. And if it's again a shockable rhythm, we will deliver the second shock here. Okay. Now after second shock, we will again resume the CPR. And at this point, after the second shock, we will give the first dose of epinephrine. Alright. The important thing here is to remember is that we don't give epinephrine immediately after the first shock. Only if the patient requires a second shock, that is the patient is still in ventricular fibrillation or pulseless VT, then we will give the epinephrine here. Okay. There is no more atropine usage. It has been removed, I think, since 2015 guidelines onwards. So no atropine has no role in cardiac arrest. Okay. So here epinephrine is given every 3 to 5 minutes. So we will target a mid-range of every 4 minutes or every alternate cycle. So every 2 minutes is considered to be as one cycle. Alright. And in this part, if the patient again requires a second shock, we will also consider advanced airway and capnography. So we might go for intubation or a supraglottic airway, and we may connect the patient to waveform capnography to monitor the end-tidal CO2 here. Okay. So after that, after that 2 minutes is over, we will do a rhythm analysis for the third time. Okay. Now, if the patient is still having a shockable rhythm, we will give the third shock here. Okay. So the patient after 2 shocks, if he is still having VF or VT, we call it that as a refractory VF or a refractory pulseless VT. So after the third shock, we will go for an extra antiarrhythmic here. Okay, and an antiarrhythmic agent like amiodarone or lidocaine is given after the third shock. Alright, and we will consider all the reversible causes of cardiac arrest. So I will tell you the sequence again. So shockable rhythm, we will deliver shock immediately. That's the first shock. Okay, then the next 2 minutes we will get the IV line and all those things. And after the second analysis, if it's still a shockable rhythm, we will deliver the second shock. And after that, after the second shock, we will give the first dose of adrenaline. Okay. Now, if the patient requires a third shock, then we will, after that, we will give amiodarone or lidocaine. Okay. And remember, epinephrine has to be repeated every 3 to 5 minutes. So every alternate cycle. So after second shock, after fourth shock, after sixth shock, you will have to give epinephrine if required that long. Okay. Now, if at any point in time, if the patient doesn't have a shockable rhythm, okay, then that means either the patient has gone into the non-shockable arm there, or the patient has attained a ROSC, right? Okay, so let's look at this 12th part here. Anytime the patient is having a non-shockable rhythm, that means if there are no signs of return of spontaneous circulation, go to 10 or 11 here. That is, we move on to the non-shockable arm here. 10 or 11 is the non-shockable arm here. Okay. Now, if ROSC is attained, we will move on to post-cardiac arrest care. If even further the patient is not having any shockable rhythm or ROSC is not attained, this might be the point of time where you consider appropriateness of continued resuscitation. Okay, whether you need to continue such resuscitation or not, you need to take a decision on that. All right, now let's see the non-shockable arm here. Okay, non-shockable rhythms can include asystole or PEA. Here, the most important thing to do is to continue CPR and to give epinephrine as soon as possible. Now, this is also a 2020 update. Okay. Before that, they used to mention that epinephrine has to be given, but studies have shown that the earlier you give epinephrine in non-shockable rhythm, the higher the rate of ROSC can be attained. All right. So you continue CPR for every 2 minutes, get IVIO access. You give epinephrine every 3 to 5 minutes. Then consider advanced airway capnography. Okay. Now, at any point of time, if the patient moves or gets a shockable rhythm, that is, the patient goes into VF or VT, you move on to the left side, sorry, the right side of the arm there. Okay, to the shockable rhythm arm there. All right. And always think about the reversible causes of cardiac arrest. Okay. Now, if the patient remains in a non-shockable rhythm, then you need to think about the appropriateness of continuing resuscitation. All right. I hope that the entire sequence is clear. Okay. And if you look at this part of these boxes here, the CPR quality we have already mentioned. 30:2 ratio, high quality CPR, all those things. Then quantitative waveform capnography, we will discuss about that. How it can be useful in cardiac arrest. Then delivering the shock here. I already mentioned we have monophasic defibrillators as well as biphasic defibrillators, right? Okay. The monophasic ones were the old ones, but some hospitals might still have that. If you have that, you need to deliver a shock at 360 joules. You need to select the energy of 360 joules. Okay. Biphasic ones, the manufacturer recommended dose is supposed to be used 120 to 200 joules. But if you are not sure what is the recommended dose, then always go for the higher, the largest dose available. Okay. Then drug therapy, we have discussed about epinephrine. 1 milligram every 3 to 5 minutes has to be given. The antiarrhythmics in refractory ventricular fibrillation of VT, it's amiodarone. The first dose is going to be 300 milligram bolus. The second dose, 150 milligram. Then lidocaine. Okay, we will go through that in detail. All right. Now, advanced airway, if the patient remains in cardiac arrest after the second shock, you need to think about advanced airway. And whenever you have an advanced airway, go for waveform capnography to confirm whether you have intubated the patient in the trachea itself. When you have an advanced airway, I have already mentioned that there is no 30:2 ratio. Go for continuous chest compression and 1 breath every 6 seconds. Okay. Now, ROSC. Okay, how can you identify whether return of spontaneous circulation has happened? First of all, do a pulse check. Okay, so we do not do pulse check every time the patient is in the shockable arm. Okay, when the patient is in the shockable arm, there is no point in checking for pulse. There is no point in wasting time checking for pulse, right? And in the non-shockable arm, if the patient is having an asystole, then also there is no point, right? But we will check for pulse only when we see an organized rhythm, okay, to differentiate whether we have attained ROSC or the patient is in pulseless electrical activity. I hope that's clear. Okay. Now, other indications of possible ROSC has been attained are a sudden rise in the EtCO2, typically more than 40 millimeter of mercury. Then intra-arterial blood pressure can also be used. We will talk about it. Then most important thing here, the reversible causes of cardiac arrest. Okay, so all these things can be found in the algorithm here. It's a very beautiful algorithm. All right. Now let's look at the next component or the next important step in the ACLS, which is monitor the quality of CPR. All right. So we use quantitative measures as well as qualitative measures to monitor the quality of CPR in ACLS. Okay. So for that, the 2020 update recommends that we assign someone the role of a CPR coach. I have already talked about this. The CPR coach ensures that the chest compressions are of high quality, ventilations are given in the proper way, and whatever is required to ensure high quality CPR, the CPR coach will facilitate that. Okay. Usually, the person handling the defibrillator will also take over the role of the CPR coach. Then 2020 update also advises us to use feedback devices to monitor the quality of CPR. The other physiological monitoring parameters which are available are end-tidal carbon dioxide and arterial diastolic pressure monitoring. Okay. So how do we do that? Okay. End-tidal carbon dioxide, you can see in this picture here. Normally, when someone is expiring, there will be elimination of carbon dioxide in the exhaled air, right? So this is the graph, the waveform or the graph will look like this. Okay. So in the inspiratory part, of course, the carbon dioxide level is going to be 0, and then you are going to see an expiratory slow uprise there. Okay, this is the upstroke here. Then it's going to plateau out, and at the end here, at the end of expiration, this part here, okay, the value, or we are actually measuring how much carbon dioxide is present at the end of expiration. This is EtCO2. All right, this is followed by inspiration. Okay. Now, we usually monitor EtCO2 in patients who have an advanced airway. All right. Now, how it's useful in cardiac arrest is that when the EtCO2 reading is less than 9 millimeter of mercury, okay, it is suggestive of poor CPR quality. How this is translated into that sort of meaning is that the EtCO2 depends, of course, on the pulmonary blood flow, which in turn depends on your cardiac output, right? So if the CPR quality is poor, cardiac output is going to be less and your pulmonary blood flow is going to be inadequate to produce or to even wash out enough carbon dioxide. All right. So in such cases, if EtCO2 is less than 10, you need to improve the quality of chest compressions. Okay. Now, what if the EtCO2 remains persistently low, less than 10 millimeter of mercury? Then it has been shown that, a lot of studies have shown that if it is remaining less than 10 millimeter of mercury for even up to 20 minutes of CPR, then chance of ROSC is very unlikely. You may have to consider stopping CPR in those cases. Now, when you get a sudden rise in the EtCO2 values up to around 35 to 40 from around 10 to 15, you have to suspect that this patient has attained ROSC. Okay. Now, the other physiological parameters which you can monitor are the coronary perfusion pressure. We have already discussed about it. Ideally, it should be more than 15 millimeter of mercury. But it's very hard to measure CPP in our clinical setting. So instead of that, we can use a surrogate marker like arterial diastolic pressure. So if patients inside your ICU have an intra-arterial line, you can connect it to the monitor and see the arterial diastolic pressure or the arterial relaxation pressure. Both are the same things. And if it is less than 20 millimeters of mercury, it is also suggestive of poor CPR quality. You need to improve the quality of your chest compressions. Okay. Or you might have to give more vasopressors. All right. So that's EtCO2 and arterial diastolic pressure. Okay. So this is how EtCO2 monitoring is done. We usually connect the adapter to the ET tube, in between the ET tube as well as the ambu bag or the bag valve device. and a sample is being taken through this line here, okay, into the multipara monitor, and it will show a reading like this, okay, here. All right, you can see this value here. That is the EtCO2 value. Okay, we should target it more than 10 millimeter of mercury. Okay. Now you can see in this example, initially as the chest compressions are being started, in the first 1 minute you can see the EtCO2 value is less than 10, okay, less than 10 here, and as the chest compressions are continued, EtCO2 value gradually increases to more than 10 millimeter of mercury. So suppose this is 10, okay, you can see it's more than 10 millimeter of mercury, and after about when it's about to reach 4 minutes, you can see there is a sudden rise in the EtCO2 level here, all right, which is suggestive of ROSC. You can see the rhythms also here. It's ventricular fibrillation here, and you can see organized rhythm. Okay. Now the next important step or the component of ACLS is administration of drugs. Okay. In BLS, we are not giving any drugs. Whenever we are giving drugs, it's part of ACLS. All right. Now there are four important drugs which you need to know about when dealing with cardiac arrest here. One is adrenaline. Okay. Then next one are antiarrhythmics like amiodarone, lidocaine, and magnesium sulfate. Now all these drugs can be given either through IV access or through an intraosseous access, IO access. So in cardiac arrest, if you are not able to get an IV access, we do not waste much time. We will go and straight away get an intraosseous access. All right. All these drugs can be delivered through intraosseous line as well. Now let's go through each of these drugs. First and the most important drug, adrenaline. All right. Adrenaline is given at a dosage of 1 milligram every 3 to 5 minutes. But what you need to remember is the strength of adrenaline here, which is 1 in 10,000 dilution. Okay. The usual adrenaline that we get in the ambule is 1 in 1,000 dilution. All right. So you need to dilute it in a 10 ml syringe with normal saline up to 10 ml, and you need to push that. And this is usually followed by a 20 ml normal saline, flush, and you elevate the arm. That's how you rapidly deliver adrenaline in a patient in cardiac arrest. Okay. Now you need to repeat adrenaline every 3 to 5 minutes. So we take the mid-range of every 4 minutes or alternate 2-minute cycles. Why we are giving adrenaline? It doesn't do any inotropic effect in cardiac arrest. It's mainly because of its peripheral vasoconstrictor effect, which is because of the alpha adrenergic effect of adrenaline. All right. The peripheral vasoconstriction increases the aortic diastolic BP, which in turn increases the coronary perfusion pressure as well as the cerebral perfusion pressure. Okay, so studies have shown that it increases the rate of ROSC. It increases the rate of return of spontaneous circulation. But all these studies have failed to show any improvement in survival to discharge or neurological outcome because of the use of adrenaline. Okay, so to get ROSC, adrenaline is very helpful here. Okay. Now let's see the antiarrhythmics that we are using in cardiac arrest. First of all is amiodarone. Sorry about the mistake here. Okay, amiodarone. All right. So when do we give amiodarone? After the third shock, right? We have diagnosed the patient to have refractory VF4VT, and after the third shock, we will give amiodarone here. The first dose of amiodarone is going to be 300 milligram IV or IO as a rapid bolus push. All right. If the patient still has a persistent VF4VT, then we can go for a second dose of amiodarone. Okay. So after next 2 minutes, if the patient is still having a shockable rhythm, we will consider giving an additional dose of amiodarone, which will be 150 milligram only. All right. The first dose is 300. The second dose, if you are giving, give half of that, that is 150 milligram IV or IO. Now, amiodarone is a class 3 antiarrhythmic which has also the actions of class 1 as well as class 2 antiarrhythmics. So, it's given in refractory via for pulseless VT. Now, lidocaine, either you can go for amiodarone or you can give lidocaine, but it has to be the intravenous preparation of lidocaine, not the regular lignocaine which we use for giving local anesthesia. Okay, so the first dose is going to be 1 to 1.5 milligram per kilogram IV or IO. All right. Usually, after that, we will wait for about 5 to 10 minutes. If the patient is still having refractory via for VT, you can consider giving a second dose, which is half of the first dose. So 0.5 to 0.75 milligram per kilogram. Okay. You can give a maximum dose of only up to 3 milligram per kilogram. So about 2 doses only we will be giving. The action of lidocaine is by suppressing the automaticity of conduction tissue in the heart. It also blocks the permeability of neuron membranes to sodium channels. Alright. Both drugs increase the rate of ROSC as well as survival to hospital discharge. Okay, so that is the advantage of giving amiodarone as well as lidocaine in shockable rhythms. It has no role in non-shockable rhythms, of course. Now, the next antiarrhythmic that we need to know is magnesium sulfate. Now, if you are seeing a polymorphic VT or something called as a Torsad depoindus, then you need to consider giving magnesium sulfate in addition to your shocks. Alright, so the loading dose of magnesium sulfate is 1 to 2 gram IV or IO diluted in 10 ml of normal saline given as a slow bolus, typically over 20 minutes. Okay, so we dilute in 10 ml of normal saline in a 10 ml syringe and we give it slowly as a bolus over about 20 minutes. Okay. Now, other than IV or IO, is there a role for endotracheal administration of these medications? Of course, if IV or IO access are not available, we can give these medications through the endotracheal route. Okay, so the patient has to be intubated in such scenarios, but the problem is that nobody knows the optimal dose. Okay, so we usually give 2 to 2.5 times of the IV dose. The problem is that for giving this through the endotracheal route, you need to stop the chest compressions. Otherwise, the drug is going to just regurgitate out. Okay, during the compressions. Now, so we usually dilute these drugs in 5 to 10 ml of sterile water or normal saline, and the drugs which we can give are epinephrine and lidocaine. Okay, so these two drugs we can give through the endotracheal route. Atropine can also be given, but it's not recommended nowadays for cardiac arrest. There is no evidence for its use. Next important thing, advanced airway, we have already discussed about this. It includes the endotracheal intubation or King's laryngeal tube, any supraglottic airway device like LMA. The final and most important thing that we have to consider in ACLS is treating the reversible causes of cardiac arrest. Okay, so what are the reversible causes of cardiac arrest? AHA offers us a mnemonic for remembering that as 5 H's and 5 T's. Okay, the 5 H's include hypoxia, hypovolemia, hydrogen ion excess or acidosis, then hypo or hyperkalemia, and finally hypothermia. Okay, those are the 5 H's. Again, hypoxia, hypovolemia, hypo or hyperkalemia, hydrogen ion excess, and hypothermia. Okay. Then the 5 T's include tension pneumothorax, cardiac tamponade, toxins, thrombosis of coronary vessels or thrombosis of pulmonary vessels. Okay. Basically, MI, ACS, and pulmonary embolism. Okay, so these are the 5 T's here. Okay, so what you need to do is that you need to think about these reversible causes of cardiac arrest during the scenario, and you need to identify and treat the most probable cause here. which will help you to attain ROSC.